Dear ladies and gentlemen, thank you for joining us at this ENS webinar. It was organized from the functional section of the ENS, and we are very happy to have you all here. I see them numbers going up at the moment, 44. And maybe I can use the time for introducing our presenters today. They are all three experienced epilepsy surgeons. Christian Dorfer is working in Vienna, in Austria, at the AKH Med Uni Wien. Marek von Lehe is working in Germany, in Neuruppin, and Thomas Blaublom is working in Paris, in France. And I think you all know all of the three already. And the topic for today is hemispheric disconnection, current state of the art. And I think every one of them puts his light on a special aspect of these kind of procedures. And I think you will hear many new things which you maybe can use in your practice at home, or maybe you can also stay with us and join us with the discussion. I would recommend to do this discussion after the three talks at the end. The talks are planned for a duration of 20 minutes. And after that, we will have a discussion of 15 or 20 minutes. So we are already 54 people. And I think I would like to get Marek von Lehe to start his presentation. Marek, are you ready to share your slides? Yeah.
Yes, everybody can see something.
Yeah.
Thank you very much. I'm very happy to be here. It's a very interesting topic, very nice procedure, very interesting things around it, like pre-surgical workup, the seizure outcome. I will start this evening with the Transylvian approach, but first I'd like to introduce some historic things about the procedure. Just a few words about the indication for this kind of surgery. And most of the time we will talk about the technique, the Transylvian approach, a lateral approach to disconnect one hemisphere. When we have time, or maybe we discuss it later in the panel, when we discuss the both procedure, we can talk about the outcome, the major goal of this surgery, the seizure outcome. So hemispherectomy is a 100-year-old story, I think. So Dandy published it on 1928. He did this procedure on glioma patients, and he reported 5 patients 100 years ago. Quinault was the first one who published data about this procedure to treat epilepsy. Interestingly, he had some pre-surgical workup for these patients. So he mentioned the EEG data, and he had some imaging like ventriculography. And Rasmussen was the one who reduced the resective part of this procedure and more and more disconnecting the tissue to treat the epilepsy. So first subtotal anatomical, and then this approach, subtotal anatomical functional hemispherectomy, with large parts being disconnected and smaller parts being resected. Here we have some sketch about the procedure. So we have a classical anatomical resection of the whole hemisphere, then the basal ganglia were left behind in some instances, and then Rasmussen developed the subtotal anatomical and functional hemispherectomy, where he left larger parts like posterior lobes or the frontal lobe and posterior lobes behind, just disconnecting them, and resect the central cortex and the temporal lobe. With this large resective procedure, we have major complications, of course. It's usually used in pediatric patients, and the smaller they are, the bigger are the problems. We have some early complications like wound infection, but some kind of hydrocephalic complication might be life-threatening, of course, like a blockage of the Monroy or something in the aqueduct. So these are major issues and are responsible for a high rate of mortality in the early days. The late sequels of the hemispherectomy are again hydrocephalic problems, but they always have some kind of neurological deterioration over the years, and this is true for a long-term follow-up of these patients after hemispherectomy. So the idea was to minimize these problems from hemispherectomy procedures, with minimizing the exposure, to have a smaller craniotomy, to reduce the blood loss even in smaller children, a big problem. And the most problems on the long run are following this enlarging of the CSF space. You have a large resection cavity filled with CSF, and most problems, hydrocephalic problems, might arise from this issue. But still, we have a very nice seizure outcome with these large resections. So the idea was to go back with resection and to disconnect more and more. So we have here just a few words about the large removal of tissue in the anatomic hemispherectomy, going through the different stages, the evolution of the disconnection rather than resection. We will hear a bit more about the vertical hemispherotomy later. So what are the indications? Just again, a few words about that. We want to focus on the technical things, of course, but what are the indication for hemispherotomy? I think it's quite easy to put an indication for this procedure, because they are clear cut and concerning the MRI results. We have primarily unilateral seizure activity. We have a refractory epilepsy. It's quite discussable to say we wait for 1 year and we try 2 different anti-epileptic drugs, which is the common thing for these for refractory epilepsy, to start thinking about epilepsy surgery. I think with a very large hemimegalencephaly and severe epilepsy, you can start thinking about epilepsy surgery quite after birth in some babies. We need an uninfected hemisphere, which is, this might be more complicated to see an unaffected hemisphere without any epileptogenic activity when you have a large and a pathological hemisphere on the other side. So the EEG has some spreading from the affected hemisphere to the healthy hemisphere. This is, let's say, challenging for the epileptologist. And we need to have an idea about the eloquent areas of the in the healthy hemisphere. And we have to discuss everything about the deficits that might arise after surgery with the family. This is quite complex and you need some time for that, but this is not the issue today. So these are some imaging results about typical indications. There's Sturge-Weber syndrome with the atrophy of the left hemisphere and typical calcification in the posterior area. This is a baby with a hemimegalencephaly on the right side with an enlarged banana-shaped hemisphere on the right side. And with these patients, these are quite frequent conditions with these infarction of the MCA and a large porencephalic defect and an atrophy of the affected hemisphere. So these are the typical indications. There's some more like Rasmussen's encephalitis and large dysplasias of one hemisphere, but mainly we have quite a circumscribed group of patients that we think about. So now we start talking about the techniques of doing hemispherotomy. Here are three typical lateral approaches doing the disconnection, and we hear about later. We hear about this technique, that vertical hemispherotomy. About these issues we will talk about later. So transerial approach with some kind of resections is typical for the transerial hemispherotomy. So I will talk mainly about the Schramm technique. He trained me, Professor Schramm trained me in my time in Bonn, so I learned from him most of my skills. Just one slide and short the different steps, and we will go through these steps a bit more in detail later. So we have a small craniotomy for the exposure of the Sylvian fissure. With the transerial approach, we have an exposure of the whole insular cortex and the circular sulcus. From this area, from the base, from the insular system, we go through the sulcus circularis to the ventricle, from the ventricle through the corpus callosum, and then we are on the mesial aspect of the affected hemisphere. Something very special is a frontal disconnection, where you don't have these landmarks like a ventricle. This is some kind of challenging, but at the end you can disconnect in all these steps. There are two steps of resection with the hippocampectomy and the disconnection of the temporal lobe, and you have to resect the insular cortex, of course, because you might have some seizures onset from this area. This is just an X-ray from the lateral view of the craniotomy. You see a craniotomy of 4 by 4 centimeters. You go through this approach to the lateral aspect of the hemisphere. You see the Sylvian fissure and open it to expose the insular cortex. You need the whole sulcus circularis for the approach to the ventricle, and one of the major landmarks is the MCA, the M1 branch, where you follow the vessel to the mesial aspect of the hemisphere. When you reach the lateral ventricle, you see the hippocampus here and the corpus callosum in the back here. You disconnect. You disconnect the frontal lobe in this area, going up from the MCA, or you go down from the frontal tip of the ventricle, and then you disconnect the frontal lobe and here the temporal lobe. The anatomic landmarks, as you see it in the OR, the patient is lying on the back, and you sit in front of the patient. So Sylvian fissure and the ventricle and the insular cortex, these are the landmarks. You use the new navigation, of course, to plan the trepanation, and you need a kind of 4 by 4 trepanation for the approach. You have just sum up in the sketch of the lateral approach and transylvian approach, a transcercal disconnection from the insular cistern to the ventricle, and we leave the basal ganglia behind, and you go from the ventricle through the corpus callosum to the mesial aspect of the hemisphere, following the vessels and the cistern here. And we have two steps of resective procedures like amygdala hypocampectomy, and you have, of course, resect the insular cortex. This is early post-op MRI in a hemimegalencephalic baby with the transylvian approach again. In these cases, it's quite nice to resect opercular window in the frontal lobe to have a better overview of the structures you need to see, and the landmarks are often shifted. So to have more space, you might resect some kind of tissue of the frontal operculum. So transylvian approach with this operculum, the basal ganglia, in this area with the disconnection above and below, the callosotomy, quite nice in this T1 scan, and you see a bit of bleeding, so you can see the disconnective area here, and amygdala hypocampectomy in this area, and the insular cortex is resected. It's just to illustrate how it looks like after a couple of years, basal ganglia and the disconnection around it, the resected hippocampus, the insular cortex is resected, and you see the temporal lobe and all other areas are still alive with blood supply, but it's disconnected. So what we have, what can we expect from the complication view? We have sometimes some kind of meningitis, usually aseptic, but the children might have high fever and some kind of meningitis signs. With the disturbance of CSF flow, when you open up the ventricle, you might have some kind of CFS fistula, and you need some kind of drainage, like an external drainage or a shunt in the later follow-up. The major issue in the early days, you need to see an incomplete disconnection. You always have to perform an MRI after this procedure, in my opinion, to go in early to disconnect the hemisphere completely if it's not completely disconnected. When you wait for 3 months, 6 months, and the seizures are back, and you go back for a second step, it's much more complicated to go there and disconnect the hemisphere. Functional deficits, it's quite hard to expect something like an increase or decrease in deficits. It's a very individual situation how the patients are postoperatively and how they improve after surgery. And you always have some kind of deficits after surgery, I think, but most of the patient, even the younger they are, the better the outcome from the deficit point of view. With very young patients, we always have problems about blood loss or temperature regulation during surgery, and just talked about the hydrocephalus, and this is something that we can discuss later, how we approach this problem. The mortality is much lower than in the early days with hemispherectomy. Of course, we have a mortality below 1% today. So just a few words about the pitfalls. The major issue is to disconnect the hemisphere incompletely. So what we have here is an incomplete disconnection in the posterior area, or here we have a disconnection too far anteriorly, you have to disconnect the frontobasal area in this area here. And this is an incomplete disconnection, and you have to know where it should be and to see where how incomplete your disconnection is after surgery. Incomplete disconnection is after these complex orientation problems much more evident because of all these shifted anatomic landmarks. You see this patient with a hemimegalencephaly where the midline is completely bent over to the other side. The insular cortex usually here is a landmark for the disconnection in the epileptogenic hemisphere might be completely shifted or even not there. You see the MCA branches here and M1 shifted backwards. So another landmark, important landmark you need for the orientation is shifted. Well, that's my talk to this point. We can talk about seizure outcome maybe later. It's just a few slides, but I think I will stop here. Thank you very much. I will stop.
Okay. Thank you, Marek, for this impressive lecture about the perisylvian hemispherotomy technique, how Schramm proposed it. And I think we have this. Thank you all for participating this webinar about this topic. And we have decided to have the discussion after the talks. So I will invite Christian to go ahead with the second talk about the vertical hemispherotomy technique. Please, Christian.
Yeah, thank you very much, Carl. Everybody seeing my slides?
Yeah, they are on.
Okay. So hello, everybody. After this nice talk on the lateral hemispherotomy techniques, I want to introduce you to the vertical approach. This is my agenda. I will talk briefly about the history, which is brief but important. Then go through the surgical anatomy of the vertical parasagittal hemispherotomy technique as suggested by Delalande. Then talk about suggested modifications to it, and then the efficacy with regard to seizure outcome and potential reasons for different outcomes. So with regard to history, this is the first image, at least that I know of, from Lane in 1952 about the voie interthalamo-caudée. Sorry if my French is not correct, but here you see the disconnection line between the thalamus and the caput nucleus caudati. And 40 years later, then Olivier Delalande first published in an abstract in 1992 his technique of a vertical parasagittal hemispherotomy, where you see the disconnection line here on the coronal view. And this technique starts with a straight skin incision and a small craniotomy precentrally located. Then you create a surgical window to gain access to the ventricle. Sometimes you can use a wide sulcus to get the entrance to the ventricle, and sometimes it's necessary to get some specimen. And this is how it looks then on the axial cuts in an MRI. You see here the callosotomy. Here is the disconnection line in the groove between the nucleus caudatus and the thalamus, all going down through the internal capsule. See here, this is on the MRI, and in the end, the complete disconnection. And the vertical technique can be described in 5 steps. We are going through these quickly. Once you have gained access to the ventricle, the first step starts posteriorly. So you need to identify the splenium and disconnect the splenial fibers until you get a view on the vein of Galen complex. Then you disconnect the fornix at this level. You follow the paracallosal artery all around the genu to complete the colossotomy. Then you have the frontal basal disconnection. You will see a short video shortly until you get subpial identification of the optic nerve, the carotid, and A1. Then there is the perithalamic cut here through the thalamocaudate groove, following the plexus in the temporal horn and opening up the choroidal fissure here. And the last step is then to connect the frontobasal disconnection and the perithalamic cut along the long axis of the optic tract. Here is a short video, so you get a better imagination of how this works out. So first step, ventricular access, small craniotomy. In this case, a piece of cortex is removed. You gain access, as shown here. And then you have to orientate yourself. You see the plexus here. Here's an outline. You have to identify the fornix, as you can see here. And then start the dissection here in the spleen. This is very important. You have to get the surface of the interhemispheric surface of the splenium. You start suctioning the splenium until you can identify then the vein of Galen complex through the subpial plane. And then you have the fornix here, and you can beautifully dissect it. And then the surface of the thalamus comes into view. Step 2 is then the colossotomy. You just follow the paracallosal artery. This is an example of it. In this case, it's a large ventricle, so it's beautifully seen here. And this is a step where you have to get a very steep angle to look all around the genu. So in most of the cases, you have to lift up the ventricle with a brain spatula. And by this, you can follow then the paracallosal artery all the way back until it's complete, as here. Step 3 is the frontobasal disconnection. You have here the foramen of Monroe. You have here the fornix. Here's the recessus. This is the anterior commissure. You came here all around the genu already, and just start suctioning the posterior part of the gyrus rectus until you identify the optic nerve. Here is A2 and A1. Okay, we have a mistake here. Then the perithalamic incision, as I told you, here's the caudate groove. We are going through the internal capsule. The nucleus caudatus is lateral to it, and here is the thalamus. You follow the internal capsule. You have here the plexus, which is your guiding structure through the internal capsule, and you unroof, if you want to, the temporal horn all the way down. Here under the paddy is the plexus, which is the most important guiding structure here. And once you have done this, you have to dissect and open up the choroidal fissure, as seen here, because you have to identify the choroidal arteries and get the idea about where the optic tract is, which is then your guiding structure to the frontobasal disconnection here. You see here, here's the hippocampus. This is the choroidal fissure, and as you know it from temporal lobe resections, mesotemporal lobe resection, opening up the choroidal fissure. And the last step is then the connection of the frontobasal part here and the perithalamic cut, following the long axis of the optic tract. And in the end, you see then through the subapial plane the basal cisterns. So what were the reasons for us? So for my mentor, Thomas Czech, in 1998 to choose the vertical approach instead of the lateral approach. It was the smaller skin incision, less blood loss, perceived less blood loss, a lower risk of inadvertently injure the healthy hemisphere. It just seemed more obvious if you have two hemispheres that are connected horizontally to come from above, vertical, to the fibers you want to disconnect instead of parallel to them. You don't need to dissect the MCA in a Sylvian fissure, and the perithalamic cut disconnects any dysplastic gray matter lateral to the ventricle, including the insular cortex and the basal ganglia. The low hydrocephalus rate at this time and a low mortality rate at this time below 5%, as Marek told us. Now it's even less, below 1%. Now, I want to briefly introduce you to the modifications that were suggested to this parasagittal hemispherotomy technique. The first one is to come from the interhemispheric fissure instead of parasagittal to it. In this illustration, even coming not through the thermocaudate roof, but lateral to it. And then a little bit later, again, coming through the interhemispheric fissure, and Thomas will tell you about his experience with that. And then again, the same procedure as for the original technique, not coming parasagittal, but through the interhemispheric fissure down to the temporal horn. And this is a suggestion of an extraventricular functional hemispherotomy technique. The main argument here was to potentially reduce CSF disturbances. You can see here by image guidance that was used in this case from here down to here to completely disconnect the hemisphere with a large craniotomy. We can discuss this during the discussion session. And the main argument, and I think Thomas will tell you also, to come through the interhemispheric fissure is the more easy orientation for the colossotomy. And then endoscopic approaches were suggested, as here from Sandeep Sood, to be somewhat minimal invasive, and also here from Sarah Chanda, endoscopic assisted interhemispheric again, transcallosal vertical hemispherotomy approach. The minimal invasive part we can discuss. Again, you see a craniotomy the same size as for the microscopic approach, but open to discussion. And then nowadays, of course, a lit procedures. So this is a case report 2 years ago with multiple trajectories and a successful hemispherotomy with multiple fibers using the lit technology. And another minimal, in this case, bloodless technique, how Sarat called it, where he used thermocoagulation. So as you can see in these examples, many trajectories mean they used 15 trajectories and over 100 coagulations. So a very extensive procedure. And then for the last couple of minutes, I want to share with you my opinion on the comparison of efficacy with regard to seizure outcome. And I want to start with this paper here, published in 21, multi-institutional experience, I think 20 institutions, where they compared the vertical approach versus a lateral hemispherotomy techniques. And this is what they got. The vertical approach seems to be a little bit better on the long run. We have 10 years here than the lateral approaches. You see here over 600 patients, and one limitation of this study, of course, is we have 600 patients with the lateral approaches and only 72 for the vertical approach, and half of it, or even 2/3 of the patients, came from our institution. So in this literature review for example, from last year, beautiful from Massimo Kosu, over 800 patients, 25 studies. Lateral and vertical techniques present similar excellent seizure outcomes. And this paper here just published a couple of days ago, where they concluded that not the surgical technique, but etiology, contralateral MRI, prior surgery, and the site of surgery determines seizure outcome after pediatric hemispherectomy. Nevertheless, there are some differences, and that may have implications for different seizure outcomes. And this is the residual insular cortex. As I told you, for the lateral techniques, resection of the insular cortex is cumbersome, I would say. For the vertical approach, this is very easy. And in this study already back in 2007, Elizabeth Katz and al. Showed us that residual intercortex was positively correlated with persistent seizures. And then, as Marek already outlined, frontal-basal disconnection. So for the lateral approaches, some surgeons use the sphenoid reach as a guidance, and then here the posterior part of the frontal-basal gyri may be incompletely disconnected. For the vertical approach, this is not an issue. And the last one is the perithalamic cut through the vertical approach. As we all know, during development, the human cortex starts from the subreticular zone, and then all the neurons migrate along the radioglia to the cortex. And in case of malformations of cortical development, dysplastic neurons may be found all the way from the ventricle up to the cortex. And this is where the perithalamic cut, as you can see here again, may be of advantage. So the take-home messages would be the vertical approach combines the advantages of a small surgical window and yet clear anatomic orientation, relatively independent of the underlying pathology. The vertical approach seems to result in a more durable seizure freedom, but as I showed you, this is controversial, and the efficacy of its modifications remain to be evaluated. The insular cortex, the frontal-basal disconnection line, and the perithalamic cut may contribute to this advantage. And before I come to end, I want to invite you to our first Congress of the International Epilepsy Society and our monthly webinars. And thank you for your attention.
Thank you, Christian, for this very precise and a very illustrative lecture and these very nice videos. As we have mentioned at the beginning of the session, we will have the discussion at the end. So I will go to Thomas, and please, Thomas, can you give your lecture about the modifications of the vertical approach?
Thomas, your microphone is muted.
Thanks. So hello everybody. So I'm Professor Thomas Bloblom, and I'm the head of pediatric neurosurgery in Necker Hospital. Thank you very much for giving me the opportunity to show this midline approach. Just a few words. We all share a common framework. After hemispheric, we want to do an hemispheric disconnection, but whether you go vertical or lateral, you want to disrupt commissural and projection fibers. It means corpus callosum, anterior commissure, limbic structures, and the internal capsule. So, looking at the results of the HOPE study, vertical seems to be better. But what is interesting in this study that the post-operative MRI was not interpreted in the multivariate analysis. Why should coming from above be better? Maybe just because of anatomical consideration. If you want to do a perithalamic disconnection, the long axis of the thalamus is postero-anterior and lateral to medial. So coming from lateral, you will have the large axis in front of you, whether if you come from above, it will be easier because you can follow a breadcrumb, which is a choroid plexus, because the choroid fissure is delimited laterally to the thalamus, and so meaning that everything that's lateral to the choroid plexus is lateral to the thalamus, and so you can follow the choroid plexus to disrupt all the projection fiber on thalamocortical fibers in a way that is maybe more easy in the vertical way than in the lateral way. For me, the intracallosal subependymal callosotomy is not obvious. The video from Christian was really beautiful because he showed us very nicely the pericallosal artery. But I thought seeing, for example, in William Harkness' department in London, the lateral approach, it was really difficult to follow the vessel from a lateral way or from a parasagittal way. If you look back in the HOPE study, you don't have 100% of patients that are cured, and you don't have any analysis of the post-operative MRI taking into consideration in the seizure outcome. So giving this premise, I will present you the interhemispheric approach, which gives you the major advantage to control in the subarachnoidal plane the whole corpus callosum. And another thing which is important is that you don't really need to preserve the striatum for the postoperative functional recovery, because there are a couple of studies, and we did a study like this, showing that most of the functional recovery that happen after hemispherotomy comes from the ipsilateral side of the healthy cortex. We show that the thalamus and the cerebellar are subcortical hubs that drive the cortical reorganization in this case. So, preserving the striatum, the caudate on the affected hemisphere is not such a big deal. And so going perithalamic directly may be a good option in order to get seizure freedom. So the steps are really comparable to the parasagittal approach, except that you perform first a complete callosotomy through the interhemispheric route. The second step is lateral disconnection. We start from behind and we go from posterior to anterior and from inferior to superior, making the junction between the temporal horn and the frontal horn. The third step is the anterior disconnection, and you have to start on the subgenual part of the cingulate, following the pericallosal artery to the posterior part of the gyrus rectus, and then following the vessels until the carotid, you do the frontobasal disconnection, joining backwards the temporal horn on the anterior choroidal point. So you end up with a section of the fimbria exactly in the same way as Christian just nicely showed. So in this approach, you have very good anatomical landmarks, because the first landmark is to follow the corpus callosum. Second landmark is to follow the choroid plexus. And the third landmark will be to follow the vessel. I will briefly show you a movie. So this is a case of Rasmussen encephalitis. It was quite developed because this child was coming from abroad. Generally, we operate them a bit earlier than this. You see, it's very atrophic already. So these are the surgical step. So first step will be the callosotomy. And I will insist in this because Christian really showed in detail already the other steps. So it's a classical interhemispheric approach. You can cut the vein, it's no problem. You can, in this case, we didn't need to cut any vein, but you can cut 2 to 3 veins. We never had any complication. Then you really have to be careful because sometimes you can have trifurcation of the pericallosal artery. You can have azygos pericallosal artery, and you really have to do a large dissection of the fissure, because otherwise you can have incomplete disconnection at this step. I recommend to perform transverse dissection of the corpus callosum with very low setting of the CUSA, because this will allow to perform extraventricular corpus callosotomy. You need to find on the midline the line of reflection of the septum pellucidum that will come into view later, because you can follow in the septum pellucidum very easily the anterior part until the genu, the rostrum, and do the section of the anterior commissure. So this will come into view very soon. You will see the two sheets of the septum pellucidum here, and you then can follow this extraventricularly doing the callosotomy. And doing this, you will see into view the pericallosal artery in the subarachnoidal cistern, and this will make sure that you are complete into the callosotomy. And for me, it's easier to do it like this than subependymal, but it's maybe a question of how you're used to this and how you perform this. And coming in the septum allows you to do the section of the anterior commissure. Then you go to the posterior third, and in the posterior third, you need to pay attention because sometimes the fornix can be very close to the corpus callosum, and you need to be very cautious in this case. In this case, it's a trifurcation of the pericallosal artery, so we had to respect this vessel here. And sorry, and we come very soon in the in the genu where we will identify the vein of Galen. We start the perithalamic disconnection, laterally to the plexus choroid on the glomus. So you see the glomus of the plexus choroid here, going in the sphenoidal horn, and using the CUSA in the thalamocaudate groove, you will very soon be in the internal capsula. And doing this, you can follow in the white matter the internal capsule, and you will be able to make the junction between the temporal horn until the anterior choroidal point to the frontal horn, going posterior to anterior and inferior to superior. And this allows the perithalamic disconnection. Once this is done, then it's time to perform the anterior disconnection. So this is the choroid plexus will lead you to the anterior choroidal point in the temporal horn. Once you've done this, you start in the subgenual part, and as you've done the complete callosotomy, it's pretty easy to go in the subgenual part. So you have here the foramen of Monro, here the fornix, and we are just in front. And you will see the pericallosal artery that you will follow until the frontal base at the posterior part of the gyrus, the rectus gyrus. And doing so, you will need to cut the floor of the frontal horn of the ventricle to be able to do the junction between the anterior disconnection and the posterior disconnection. And this will bring you above the Sylvian fissure in the anterior perforated space. And this is not really a problem as you can manage the perforating vessel pretty easily. We generally finish the surgery with a section of the fornix on the fimbria, just behind the thalamus, and you need to go gentle at this part. I think hemostasis is really important. We never put any things like Surgicel or this kind of things. We use Flowsil because you can rinse it, so you don't have any foreign part in the brain. And I think it's important to prevent post-operative central fever. We close the callosotomy with fibrin glue in order to obtain sealing of the callosotomy and of the CSF space to avoid pericerebral collection. Just a few words about the outcome, and I will finish soon. Sorry. So we performed 39 surgeries during the last 9 years. It's a bicentric cohort because there are 8 cases that were operated with this type of surgery in Taipei, in Taiwan. So as you see, we have half of the patients are atrophic because they have stroke or Rasmussen, and nearly half of them are developmental disorder with hemimegalencephaly and focal cortical dysplasia multilobar. I excluded from the study 4 cases because we needed to do either an hemispherectomy for one case and a combined interhemispheric and de Lalande approach for 3 other cases of hemimegalencephaly, and we will have a word about this. Results, we perform always post-operative MRI at day 1, and we had a complete disconnection in 34 out of 39 cases. Residual connection were seen more in the hemimegalencephalic cases, 3 cases, and 2 cases for stroke and Rasmussen encephalitis. Interestingly, for stroke and Rasmussen, it was because of insufficient dissection of the interhemispheric fissure with unexpected callosal residual on the genu because of the orientation that was not sufficient to control completely the corpus callosum. So I insist on the fact that you need to do extensive dissection of the fissure in this case. For the hemimegs, we always add perithalamic residual, and it's really important to look at the volume of the thalamus to be able to go enough laterally with the interhemispheric approach. Complication, 1 case of hydrocephalus out of NAR 39, 4 cases of subdural collection that we treated with subduroperitoneal shunt, 4 cases of transient polyuria for 2 or 3 days that resolved spontaneously. On central fever, we have 8 cases from Taiwan with central fever and only 2 cases in the Necker cohort with central fever. So 89% of the patients were seizure-free after the first surgery. These are the post-operative MRI for some examples. And so we did redo surgery for 4 patients because they had seizure relapse, or because in one case we saw that the residual in the corpus callosum was not acceptable. 3 out of 4 cases were seizure-free after this redo surgery. On 1 case, despite of apparently complete disconnection, still has seizures on the last follow-up. So this is a follow-up. 37 cases are ALE class 1, 1 ALE class 2, and 3 ALE class 3. Half of the patients have reduced or withdrawn anti-epileptic drugs, but this is more related to the duration of follow-up actually than on the etiology. This technique clearly has some limitations. You won't do this kind of surgery for these patients. You need to have ventricle to perform the perithalamic disconnection. And if you have atretic ventricles, like in this case of hemimegalencephaly, this is clearly impossible. And in this case, you will have to try to combine maybe an interhemispheric approach plus a perisagittal one. But I must confess that this case is very challenging because we don't have any lumen inside the ventricle, and it's very tricky, and this kid is not seizure-free. The other important thing is the thalamus size, because the larger the thalamus is in hemimegalencephalic case, the more lateral the temporal horn will be, and the more difficult it will be to do the perithalamic disconnection. So be careful about this. You need to look at the thalamic size before you choose to go for the perithalamic approach and the interhemispheric approach. Next part, the callosotomy, you really need to do complete follow-up of the pericallosal artery to do extensive dissection of the fissure to really control the splenium with the vein of Gallen complex and the genu and the rostrum with the vision of the pericallosal artery in the interhemispheric fissure. So this is only a variation of the parasagittal approach. This is not new. This is something maybe you need to think about if you think that the subependymal callosotomy is difficult. It gives good outcome. I think the advantage of this technique is the callosotomy under direct vision, and that you have very clear anatomical landmarks, the choroid plexus and the vessels. Clearly, there are limitations of this approach for very complicated hemimegalencephalic case, atretic ventricle, large thalamus, and in this case, you need to consider other type of approach with at least some kind of resection of the superior frontal sulcus or combined approach, parasagittal and lateral, for example, not to be too dogmatic. So I thank you for your attention, and it's time for question.
Thank you very much, Thomas, for this very nice lecture, and especially for sharing with us your technical nuances and tricks for these procedures, and also for sharing us these results also about the redo surgeries. So there are still 75 participants online, and I would like to start the discussion with the first question about the weaknesses of the different techniques. So I would like to ask Marek and then you both, Christian and Thomas, about the weaknesses. Marek, what do you think about these insular cortex resection during the perisylvian technique? I had the advantage to do both techniques, and I found the perisylvian technique very, very I felt very unpleasant to do this surgery because of dealing with MCA vessels and insular cortex. And Thilo Kalpen told me about his modification about the resection of the insular cortex, where he didn't resect, but he disconnected. Marek, can you comment on that?
With a classical Transylvian approach, without any opercular resection, you have not the space to go around and disconnect the insular cortex, I think. Well, one of the weaknesses is that you have to approach the insular cortex from the front. You cannot go around it. You have to resect it, I think. Go just Transylvian for the Transylvian approach. Well, you might be some kind of scary about these M2 and M3 branches, but the good thing is you can coagulate them. You don't have to, of course, and you might end up in problems with insides. You may have some brain swelling with larger infarcts with a disconnection from the lateral way, but it's not very important because an infarct is not. There's no result of it, so you can deal with these branches quite, let's say, brutally. But you have to resect the insular cortex, and this is very important. And I think one of the problems of the HOP study is that the MRI wasn't included in the analysis. You have to do an MRI, and you have to look carefully for the insular cortex. And so this is one of the weaknesses of this approach. You have to go for it, and you are not allowed to stop until you resect the insular cortex completely. The other one is, I think, Thomas, you mentioned it, you can reach the other side, the healthy hemisphere, when you come from the lateral approach. And this is especially problematic with the megalencephalic brain, because the vessels are completely shifted. The corpus callosum on this side where you come from might be much thicker than you expect and everything else. So you have to look carefully for the images. And but this is a problem with every approach. The more the anatomic structures are shifted, the more problems you have, of course.
Yeah, and the consecutive question for Christian would be, I think one of the weaknesses of the parasagittal approach for the vertical technique is maybe that sometimes fibers from the splenium might be overlooked. What do you think about that, Christian?
I mean, I agree that coming from the ventricle and do the colostomy from inside to outside can sometimes be challenging, but the beauty of it is that you really have your landmark. So once you have come and identified the achronoid to the vein of Galen complex, you know you are through it. If you don't see it, you don't have any control of it. So I think key is that you have your landmarks and do not stop until you have your landmarks, because, and I think this is way more important than using an MRI, for example, postoperatively, because I find it difficult after surgery, even for the intraoperative MRI, to really get an idea if there is a small remnant of a connection or not. Even for the callosotomy procedures, it is very hard to tell from the intraoperative or immediate post-op MRI if there is residual or not. It really comes back to the surgeon to decide if it's complete or not. Was I there? Did I get my landmarks or not? If you have them, it's so clear that you are through it. For coming through the interhemispheric fissure, I agree that it's easier to do the callosotomy. We were always reluctant to do so because the main argument for us to do the vertical approach over the lateral approach is not to interfere with the healthy hemisphere. And if you come through the interhemispheric fissure, so at least in my experience with callosotomy, you sometimes have this very, kissing so I'm missing
brain tissue.
Yes, the gyri. So sometimes it's almost impossible not to have small cortical lesions on the opposite side, and you have to dissect the callosal arteries. For sure, the orientation is easier, especially at the beginning. So this is, I acknowledge, the most tricky part at the beginning, at the splenial side, to identify the interhemispheric fissure and to identify the pericallosal artery. But once you have it, you can easily follow it. So I think it really comes from the etiology. So in hemimegalencephaly, every approach is difficult, right? If you have a porencephalic cyst after a stroke, you can go Transylvanian, you can use the parasagittal vertical, you can go whatever you want to. It's way easier. Even so, with large ventricles, especially, also the vertical approach is much easier than with small ventricles. And the strength of the parasagittal vertical approach, I would say, is that it is relatively independent of the underlying pathology. So as Thomas told us, and this would have been my question, because with a large thalamus, you have to push the brain quite hard laterally to get the lateral disconnection line. And he beautifully showed us this in the limitation of this technique. Yes.
Thank you very much. Thomas, what is your personal feeling about weaknesses of your approach or your modification, your midline approach?
No, I fully agree with Christian. Sorry. So looking back, so we've looked back to the whole cohort now to see where we failed, actually, because that's something, when you look at the literature about hemispherotomy, you don't see people looking at their failure. So when we went back to the cohort in Necker, it was about looking at our failures to understand. First step, I think, important is to see that most of the studies published on hemispherotomy don't talk about postoperative MRI, because most of them are written by neurologists, and they forget that the surgery that decides the outcome of the patient. So I think it's very important to say this, because if the hemispheric disconnection is not complete, then it can explain why the patient is not seizure-free. So I wanted to really talk about this, because I think it's very important. So do the postoperative on MRI on day one. What we saw is that in our hemimegalencephalic case, with this technique, we had 3 patients with remnant fibers on the perithalamic fibers. because it was difficult to go laterally, clearly. What I learned from going back to this study is that we have a cutoff of the thalamic angle on the thalamic volume. And for them now, what I would do is to perform the combined approach, is to go, because I'm really more comfortable with the interhemispheric approach for the callosotomy. So to control the callosotomy and the interhemispheric approach, but combine it with the parasagittal approach to be really above the thalamus when the thalamus is really large, with a resection of the F1, F2 sulcus to be just above the atrium of the ventricle, to have the control there. So that's really an important point. Otherwise, you don't need to have a very big lumen inside the ventricle. I do this on, multilobar MCD, Rasmussen at the beginning of the disease. As you know, as you have a wide dissection of the fissure, then you have more space, maybe than with a small corridor with the parasagittal approach. Regarding contralateral lesions, I think the fissure dissection is not a big issue for the babies. We operate the Hemimeg on the MCDs between 3 and 5 months, 4 months, 6 months. And at this stage, you have large subarachnoidal space, and it's quite nice to dissect it. You need to take some time. What is strange is that the case where we had the difficulties you were mentioning, I think it happened twice. It's in patients who had a perinatal stroke because they had a cardiac disease, and they had a stroke related to a cardiac procedure, and I think they had some kind of subarachnoid hemorrhage maybe at this stage, or this kind of thing, and there was inflammation in the subarachnoidal space, making it a bit more difficult to dissect. But you always find my boss, my mentor, Professor Saint-Rose, is the one who taught me to do this technique. He always told me, when you do an interhemispheric approach, the first thing you have to find is an artery, because the artery is a more solid part of the brain. So you can use your forceps to dissect between the forks on the artery, and doing so, you don't, create lesions. And you always find a corridor. And once you have the corridor in the pericallosal space, then you come backward and you can really find the plane. So we don't have contralateral lesion related to the dissection.
And what about phonics? Especially in the posterior part,
that's right.
That the phonics is coming to the corpus callosum.
I fully agree, and I'm always really stressed for the Hemimeg, notably, because for the Hemimegs, sometimes you have a very large splenium. Sometimes it's very thin when you have a large ventricle, because some hemimegalencephalicas are very easy, actually, if they have a very large ventricle on a small callosum. But I think it's in the PI3K mutated case, we have very large brain with very small ventricles, and the callosum is the posterior part of the corpus callosum is large and very close to the fornix. And so what you have to do is to be a bit paramedian in this case. So is going lateral in the posterior part to be sure not to disrupt the fornix, but we never had this problem. Yeah.
Thank you very much. I will start with the Q&A section. Olaf Schlins is asking if there are favorite indications for the one or the other technique. It's first question. Who wants to comment on it?
I think, Kai, you are one of the, let's say, 3 or 4 in the world who do the one and the other one.
I do not both. I did Barry-Sylvian, but I only do now vertical.
Yeah, but to have one and the other technique in hands is, well...
I did the lateral, or I saw many lateral hemisterectomy with James Radka at Sick Kids. And I was quite astonished, because I came from the vertical, that's a beautiful approach. And then I went there and they did the lateral approach. And for me, it was a huge procedure, a huge skin incision and a large craniotomy. I mean, the the advantage that I see for the lateral hemispherotomy techniques is when it comes to postoperative brain swelling. Because in many techniques, when you come from the lateral, you do a temporal lobe resection, or at least an opercular resection from the frontal operculum, the temporal operculum. And if you have postoperative swelling, like an MCA infarction from your dissections, then there may be an advantage if you have resected some part of the brain.
Maybe another question in between. What do you think? Do we recommend technical adjuncts for the surgery like neuronavigation? Who wants to comment on this? I saw it with Thomas' technique. He's using neuronavigation, I think.
Yeah, but I mean, we use it for all the cranial cases. So
yeah,
Okay.
I think for the vertical parasagittal approach, the neuronavigation is quite helpful at the beginning when you are planning your craniotomy, because as I mentioned, for going around the genu, you can have a very steep angle. So it's important not to be too posteriorly. If you are very posteriorly, then the splenial dissection is easy, but you can have a very hard time to go all around the genu. So at the beginning, to plan the craniotomy, neuronavigation is of help. And then during surgery, again, for the part where you go around the genu, it's of help to stay in the midline and not cross to the other side, because you know the skull base and all the so the skull base is always the same, right? So there's no brain shift, and it's of help to know how far away you are from the skull base in these dissections.
Yeah. Faisal wants to know if what to do with hemimegalencephaly patients where you want to use the midline technique and where you can't identify really a good dissection plan. What would be your surgical strategy then? Maybe Thomas can comment.
So really the problem, it's mentioned in Olivier Delalande's paper, it's when the ventricles are atretic. You have some cases of hemimegalencephaly where the lumen of the ventricle is nearly virtual in some places. These are the cases that are challenging because you don't have any anatomical landmarks that you're used to, meaning that it's a hell. So for this, I don't have a very good counsel. I failed on this case. I'm pretty sure I will fail again. I wonder if for these cases, sometimes it's not a good indication to perform a hemispherectomy, even if there is a large mortality. But currently I have a case where the kid is not cured because I didn't manage to disconnect everything because he clearly doesn't have any ventricular lumen. So for this case, I'm really open to suggestion because it's really tricky.
Thank you for being honestly. The second question of Faisal is, do you coagulate the choroid plexus at the end of the hemispherotomy? Who wants to comment? Or
We do not, but I know there is the paper from Arya Fala in Neurosurgery published 2 or 3 months ago, where they published a series on doing this and where they concluded that if you coagulate the choroid plexus, this may reduce the rate of postoperative hydrocephalus.
Yeah. And the second question from Olaf, do you think there is a place for the minimal invasive technique, and will this change the approach in the coming years?
I mean, it depends what you call minimal invasive. So if you call minimal invasive by using an endoscope and doing the same procedure, but using the endoscope as your light source, then I would say there is no future for this. For the lid therapy, I think for hemispherotomy there is no place, but maybe for some residual redo hemispherotomy cases, it can be of value. And for the thermocoagulation procedures, I'm not really sure, because if you need to do 15 trajectories with over 100 coagulations, it's a very, very extensive procedure. So I don't see a real future for this. But yeah.
Thanks. Marek wants to comment.
Can I ask you about the redo operations? When do you prefer to do that? After 3 months looking for the seizure outcome and then go back when you do the MRI the first day after surgery and you see, or you have a suspicion that there is something left, and just wait for it, or just go for a redo? What are your recommendations for that?
I mean, if there is a very clear indication, so for example, a stroke patient where we know that the rate to gain seizure freedom is close to 100%, and there are still seizures after that, and you as a surgeon had a bad gut feeling that at this one place you are not sure if you're 100% through it, and then there is MRI, and with you as a surgeon remembering the surgery with the MRI, then you can decide if there is residual, and then you can go for it. But looking at an MRI without the opinion of the surgeon, of the operating surgeon, is, I think, useless.
Thomas, your redos, were they early or late?
So in the series we have 5 patients with incomplete disconnection. I don't agree with you, Christian, on the fact that because there are clear anatomical landmarks that can be identified. You can follow the corpus callosum on if your radiologist comes to your epilepsy meeting and that you discuss together. I clearly think that it's not about the opinion of the surgeon, but it's about really clear analysis of the postoperative MRI.
Right, so, but the key is talking together.
That's right.
There's another question from Ellen Forster. Do you use intraoperative monitoring in these cases? And is it possible to identify residual tracts by intraoperative monitoring?
So I don't see how it would help. Maybe intraoperative MRI would help. I saw some paper, they were the guys doing DTI and this kind of things, but yeah.
I think this could not really help for being sure that it's completely disconnected, the hemisphere.
I don't think that the polymyalgia tract is a problem for incomplete disconnection. This is quite easy to disconnect. The more problematic is frontovasal area, fornix, temporal lobe posterior, temporal lobe. I never think about this adjunct intraoperatively, but well.
Marek, one question for you, Marek. If it turns out that vertical is really significantly better seizure outcome, would you change to the vertical technique? Yes.
Yes, of course. At the moment, I'm feeling very, very comfortable with my technique. I learned it from Tram, and he was very fast, and it was an intuitive procedure going along the vessels and then finishing. was my impression always when he did it, and I'm not there, I think, but for me it's a very nice approach from the lateral disconnection. But if somebody can say, well, with post-op MRI, with a complete resection of the insular cortex, and it's still not the vertical approach is then better, well, I would change. The problem is that you have a learning curve and you don't have a lot of cases. It's much easier to learn the temporal lobe resection, of course.
And if you're doing 10 or 15 or 20 years the lateral approach, then change to the vertical approach, this is a huge change, right? So then the learning curve comes into place. So I'm not sure if this is then. So if I think you have to choose it right away, it's at least I had these discussions with some colleagues that are doing the lateral hemispherotomy techniques for decades.
Maybe you're calling me dinosaur.
They are not willing to change because yes.
Maybe I've missed it, Thomas, but did you reduce early or late? And what is late for you and what is early?
So the mean delay was 7 months because one of the patients was reoperated 18 months because of late seizure relapse.
Yeah.
The other one, there was one patient we reoperated 2 months after surgery because we had seen on the post-operative MRI that he still had a connection and it was a stroke, and we felt it was unacceptable just to leave it this way. On the 2 others, they had a relapse very early, as you can see on the survival curve, after the surgery. But it was something, the relapse a few days afterwards. But I'm not lucky enough to have places in the OR like when I want, because we are quite busy. So I had to reschedule the case a couple of weeks after. But it's not, redo surgery is not such an issue, except that there is a reason why you failed for the first time. And if you don't think about it, then you do the same mistake afterwards. At least I did. So there's one patient I reoperated 3 times, and that's why, I told you, maybe if the thalamus is too large, change the technique. You will not get it,
So there are additional questions in the Q&A. The utility of the EEG in suspicion of incomplete disconnection. It's no. Martin doesn't ask if he means intraoperatively or postoperatively.
I think it's post-operative. If the patient has seizure, you record them and you see them going from one side to the other. So I think it's pretty useful in this case because it confirms and it gives you maybe an orientation, like whether it's anterior or posterior, to have a look at the post-operative MRI in a close collaboration with all the team.
Yeah. Another question from Ellen Forster is the cortical evoked potential. Is there a place for it or an advantage?
I have no experience.
I think maybe in surgery around eloquent speech areas, but maybe not so much in hemispherotomies. Okay, we are through with the questions. Thank you very much for these wonderful talks and very informative answers of our questions. And it was really a pleasure to moderate this session. There are still 66 participants on air, so it was really a success, I think, this webinar. And thank you so much. And I wish you a nice evening all together.
Thank you for the discussion.
The audience.
Thank you very much.
Thank you. See you soon.
Bye.
Thanks.